Meningitis. Etiology. Meningitis, inflammation of the leptomeninges, can be caused by bacteria, viruses, or rarely fungi. The term aseptic meningitis principally refers to viral meningitis, but meningitis with negative cerebrospinal fluid, CSF, bacterial cultures may be seen with other infectious organisms, Lyme disease, syphilis, tuberculosis, parameningeal infections, brain abscess, epidural abscess, subdural aphyema, chemical exposure, nonsteroidal anti-inflammatory drugs, intravenous immunoglobulin, autoimmune disorders, and other diseases, including Kawasaki disease. The organisms commonly causing bacterial meningitis, Table 100.1, before the availability of current conjugate vaccines were Haemophilus influenza, Streptococcus pneumoniae, and Neisseria meningitidis. In the United States, the rates of H. influenza type B and S. pneumoniae meningitis have declined substantially after the introduction of targeted vaccines. The bacteria causing neonatal meningitis are the same as those causing neonatal sepsis, see Chapter 65. In older children, S. pneumoniae and Neisseria meningitidis remain the most common causes of bacterial meningitis. Staphylococcal meningitis primarily occurs after neurosurgery or penetrating head trauma. Partially treated meningitis refers to bacterial meningitis complicated by antibiotic treatment before the lumbar puncture, LP, which may result in negative CSF cultures, although other CSF findings suggestive of bacterial infection persist. In this case, the etiology can sometimes be confirmed by polymerase chain. Reaction of the CSF. The most common viruses causing meningitis are enteroviruses and pericoviruses. Other viruses that can cause meningitis include herpes simplex virus, HSV, Epstein-Barr virus, EBV, cytomegalovirus, CMV, lymphocytic choriomeningitis virus, LCMV, many arboviruses, see Chapter 101, and HIV. The mumps virus can cause meningitis in unvaccinated children. Less frequent infectious causes of meningitis include Borrelia burgdorferi, Lyme disease, Bartonella henselae, cat scratch disease, Mycobacterium tuberculosis, Toxoplasma, fungi, Cryptococcus, Histoplasma, blastomycoses and coccidioides, and parasites, Angiostrongylus cantonensis, Naegleria fowleri, Balis ascaris, and Acanthamoebia. Laboratory and imaging studies. If bacterial meningitis is suspected, an LP should be performed unless there is evidence of cardiovascular instability or of increased intracranial pressure due to the risk of herniation. Routine CSF examination includes a white blood cell count with differential, protein and glucose levels, and gram stain, Table 100.2. CSF should be cultured for bacteria, and when appropriate, fungi and mycobacteria. PCR is used to diagnose bacterial as well as viral meningitis. Peripheral leukocytosis is common, and blood cultures may be positive depending on the organism and whether there was antibiotic pretreatment. Ideally, CSF should be obtained prior to empirical therapy. However, antibiotics should not be delayed if there is an inability to perform an LP. If imaging is required prior to the LP, blood cultures should be sent and antibiotics started prior to a computed tomography, CT scan. Interpretation of CSF in children who received prior antibiotics is complicated. In meningococcal meningitis, CSF can rapidly become sterile, often within 1 to 2 hours, and most commonly with a single dose of therapy. Sterilization of the CSF in S. pneumoniae meningitis may also occur within a few hours. In these cases, PCR is useful in identifying causative bacteria. Differential diagnosis. Many disorders other than meningitis and encephalitis may show signs of meningeal irritation and increased intracranial pressure, including trauma, hemorrhage, rheumatic diseases, and malignancies. Seizures can be associated with central nervous system infection, or can be the sequelae like brain edema, cerebral infarction or hemorrhage, or vasculitis. Treatment of bacterial meningitis focuses on sterilization of the CSF by antibiotics, Table 100.3, and maintenance of adequate cerebral and systemic perfusion. Due to increasing S. pneumonia resistance, an empiric third-generation cephalosporin plus vancomycin should be administered until culture results and antibiotic susceptibility testing are available. Ceftazidime, cefepime, or ceftriaxone are also adequate to treat N. meningitis, H. influenza, and some E. coli. For infants younger than 2 months of age, ampicillin is added to cover the possibility of Listeria monocytogenes. Duration of treatment is 5 to 7 days for N. meningitis, 7 to 10 days for H. influenza, and 10 to 14 days for S. pneumoniae. Meningitis caused by gram-negative bacilli should generally be treated a minimum of 21 days, or 14 days beyond the first negative CSF culture, whichever is longer. Dexamethasone as adjunctive therapy initiated just before or concurrently with the first dose of antibiotics significantly diminishes the incidence of hearing loss resulting from H. influenzae meningitis. The role of adjuvant steroids for diminishing neurologic sequelae and mortality for pneumococcal and meningococcal meningitis in children is less clear. Supportive therapy involves treatment of dehydration, shock, disseminated intravascular coagulation, syndrome of inappropriate antidiuretic hormone, SIADH, seizures, increased intracranial pressure, apnea, arrhythmias, and coma. Adequate cerebral perfusion must be maintained in the presence of cerebral edema. Complications and prognosis. SIAD may complicate meningitis and necessitates monitoring of urine output and fluid administration. Persistent fever is common during treatment, but also may be related to ineffective treatment or immune complex-mediated pericardial or joint effusions, thrombophlebitis, drug fever, or nosocomial infection. A repeat LP after 48 hours of therapy should be considered for those whose condition has not improved or has worsened, gram-negative meningitis, and for those who received adjunct steroids, which can interfere with the ability to monitor clinical response. CNS imaging should be considered in children who demonstrate focal neurologic signs or symptoms or persistently positive CSF cultures. CT with contrast or magnetic resonance imaging, MRI, is used to detect subdural effusions with S. pneumoniae and H. influenza meningitis, or brain abscess associated with gram-negative organisms. Citrobacter cocceri produces neonatal meningitis with a high incidence of brain abscess formation. Neurosurgery should be consulted to consider drainage if a brain abscess is present. With current management, the mortality rate for bacterial meningitis in children remains significant, up to 15% depending on the organism. Morbidity and mortality are highest with S. pneumoniae. Of survivors, up to 30% have sequelae, including deafness, seizures, blindness, paresis, ataxia, or hydrocephalus. All patients with meningitis should have a hearing evaluation before discharge and at follow-up. Learning disabilities and behavioral problems may be more subtle, long-term consequences of infection. Careful developmental follow-up is important. Poor prognosis is associated with young age, long duration of illness before effective antibiotic therapy, seizures, coma at presentation, shock, low or absent CSF white blood cell count in the presence of visible bacteria on CSF gram stain, and immunocompromised status. Rarely, relapse may occur 3 to 14 days after treatment, possibly from parameningeal foci or resistant organisms. Recurrence may indicate an underlying immunologic or anatomic defect that predisposes the patient to meningitis. Prevention. Routine immunizations against H. influenza and S. pneumococci are recommended for children beginning at 2 months of age. Quadrivalent vaccines against N. meningitis, serotypes A, C, Y, and W135 are recommended at age 11 or 12 years, with a booster dose at 16 years, and for children older than 2 months who are at high risk of infection, including functional asplenia, complement deficiencies, and travelers to or residents of hyperendemic areas. A newer vaccine against N. meningitis serotype B is currently recommended for high-risk patients 10 years and older. Chemoprophylaxis with rifampin, ciprofloxacin, azithromycin, or ceftriaxone to eradicate the carrier state and decrease transmission is recommended both for index cases with N. meningitis and for their close contacts. For invasive H. influenza type B, prophylaxis consists of rifampin.